I'm grateful for the privilege of presenting to the committee today on the distributions of the U.S. and Canadian sodium and potassium intakes. I was asked to present not only in the intakes on milligrams per day, but their ratio and their densities and the sources of sodium and potassium intake, and to compare urinary and dietary measures, as well as describe the strengths and limitations of the population intakes and how they might affect results. So all of this in 20 minutes, and I'll try my best. Okay, so the data sources that I'm going to present today come from the Canadian Community Health Survey, the U.S. National Health and Nutrition Examination Survey, or NHANES, and the Salt Sources Study. All three data sources use 24-hour dietary recalls. As Kate described the strengths and limitations of those earlier, and in NHANES, 24-hour urine was also collected in 2014. I'm going to describe the methods briefly for the Canadian Community Health Survey and NHANES, and just before presenting the results for the Salt Sources Study, I'll go over those methods. So the Canadian Community Health Survey, since the 2005 report, the most recent data is 2004, and as indicated today, more recent data from the Canadian Community Health Survey in 2015 should be available later for the committee. The 2004 sample is from a nationally representative, non-institutionalized persons. Diet data in 2004 is presented in a series of reports, such as the one shown on the right. The population estimates presented today are going to be based on the bean from the first day 24-hour recall, and they exclude salt added at the table, supplements, and antacids. What we eat in America is the dietary component of NHANES, and it includes a sample of nationally representative, non-institutionalized persons of all ages. 24-hour dietary recalls were collected with the USDA 5-step automated multi-pass method shown on the right-hand side. And the population estimates I'm going to present today exclude salt added at the table, supplements, and antacids. I forgot to tell you, data tables were provided to the committee as handouts, such as they were for the previous report, and additional tables are available upon request. Oops. An NHANES 24-hour urine collection was collected in 2014 among a random half sample of non-pregnant adults aged 20 to 69 years of age. The flow chart, oops, wait a minute, let me go back. Flow chart shown here on the right shows of 1,103 randomly selected participants, 827 completed the first collection, which is 75%, and incomplete specimens were excluded based on urine volume, a questionnaire duration, and for females if they were menstruating. Population estimates presented today are based on the first 24-hour urine collection. So I'm going to show the results for sodium first, and then I'll show the results for potassium and their ratio. So this shows the mean daily sodium intake by DRI age sex group for Canada in 2004. And as you can see, mean intake varies from about 2,000 milligrams for children aged 1 to 3 years of age, goes up progressively with age group in children, and is highest among males at about 4,000 milligrams, is slightly lower in older age males, and is lower among females. Similarly, mean daily sodium intake by DRI age sex group in the United States in 2009-2014 is presented here. We also, oh, that's a little better, isn't it? Sorry about that. We also have estimates for infants, which are presented in your data tables, and you can see that for infants, estimates are less than 1,000 milligrams per day. And in the U.S., Estimates of mean sodium intake in males are above 4,000 milligrams for males 14 years of age to 70 years of age. So released today are data on estimated 24-hour urinary sodium and potassium excretion, which is presented online in JAMA. The mean 24-hour urinary sodium excretion for non-pregnant adults 20 to 69 years of age is 3,608 milligrams overall. Higher in males at 4,205 milligrams, and the bars show 95% confidence intervals, and 3,039 milligrams among women. Shown to the right of the estimates for the urinary 24-hour urine estimates are estimates based on the initial dietary recall in 2013-2014 for non-pregnant adults aged 20 to 69 years of age. And as you can see here, estimates are similar to the urinary measures, both overall and by sex subgroup. So this figure shows the sodium intake distribution among adults aged 19 years and older by sex in the United States from 2009 through 2014. And the takeaway point I want to make on all of these distributions, and I'm going to go over this one in a little bit more detail than the other ones, is that there's a wide variation in usual or long-term average sodium and potassium intake across the population. So for example, the mean sodium intake for women is about 3,000 milligrams, with half of women having usual intake levels above that level and half of them having below that level. These percentile plots show the percentiles from the first percentile up to the 99th percentile. So this figure shows that about 1% of women have intakes of 15, what happened? No signal? Okay, great. Have intakes of 1,500 milligrams or less, and about 1% women have intakes of 5,000 milligrams or greater in the U.S. population. And for men, the first percentile is 2,000 milligrams, whereas the 99th percentile is 7,000 milligrams. This figure shows the sodium density distributions for adults 19 years and older by sex in the United States, and the takeaway point from here is that the distributions overlap after you adjust for energy. I'm going to switch to results from the salt sources study, and I'll also talk about food types contributing to sodium intake in the United States using the National Health and Nutrition Examination Survey data. So the salt sources study was conducted in 2013 through 2014 to update a more than 25-year-old study on the sources of sodium intake in the United States that was conducted in a small convenient sample of 65 adults. This sample was conducted among 450 non-pregnant adults aged 18 to 74 years of age in 4 race ethnic groups in 3 geographic locations in Minneapolis, St. Paul, Minnesota, Palo Alto, California, and Birmingham, Alabama. After a baseline clinic visit, 4 record-assisted 24-hour dietary recalls were collected, and participants on the day before each recall collected duplicate salt samples where they collected the amount of sodium, or they shook the amount of sodium that they added at the table and they added during home preparation or home cooking into baggies, which were then sent into the University of Minnesota and weighed. Data was also collected on dietary supplements and non-prescription acids and on home tap water, with some supplements being collected. The estimates shown here today represent the mean proportions based on 4 days per person for various sources. As you can see in this study sample, the mean total sodium intake was 3,500 milligrams per day. About 71% on average of sodium was added outside the home by food manufacturers during preparation, for example, in restaurants. Only 14% of sodium consumed was inherent to food or naturally occurring. 5% was added at the table, 6% in home food preparation or cooking, and less than 1% from other sources such as dietary supplements and tap water. Oh, I'm just going to keep going. Okay, let's see. This slide shows the top 10 food types contributing to sodium intake in the United States for U.S. persons aged 2 years and older in 2013-2014. The takeaway point from this slide is that the majority of sodium intake does not come from just one sort of single food type. It comes from multiple food types, and it also comes not only from foods that we think of as containing more salt, like pizza or cold cuts and cured meats, but those which are moderate in sodium, like yeast breads, but that we consume on a regular basis. I'll show the results for potassium. This shows the mean daily potassium intake by DRI age sex group in Canada in 2004. And as shown for sodium, there's variation in mean intake by age, maybe not as dramatic, and by sex. It shows the mean daily potassium intake by DRH sex group in the United States in 2009 through 2014. Again, you see the estimates for infants, and the estimates vary by sex. Mean 24-hour urinary potassium excretion in adults 20 through 69 years of age was 2,155 milligrams overall. 2,399 milligrams for men, and significantly lower for women at 1,922 milligrams. Dietary estimates are shown to the right of the urinary estimates, and you can see that for the dietary estimates, they're significantly higher, both overall and for men and for women. This shows the potassium intake distributions among adults 19 years and older by sex in the U.S. And as you can see, usual long-term average potassium intake varies from about 1,000 milligrams at the first percentile for women to a little above 4,000 milligrams at the 99th percentile, and for men at the first percentile from below 1,500 milligrams to above 5,500 milligrams. This shows the top 10 food types contributing to potassium intake in the United States in 2005-2006 for the U.S. population aged 2 years and older. We can also produce this updated information for you if you would like that. But as you can see, again, the majority of potassium intake doesn't come from just one food type, and it comes from sources which are considered higher in potassium, like milk, but also commonly consumed foods which are moderate or lower in potassium, like coffee. And actually, I was surprised about this, and 80% of the reports for coffee are based on just black brewed coffee or instant coffee. So it's not necessarily coffee with milk added. Now I'll show results for the sodium to potassium ratio. The mean sodium to potassium ratio for the DRI age sex groups are shown here for the United States. And to sort of follow up on what Larry was saying earlier, there's a pretty wide variation in sodium to potassium ratio, and it varies from less than 1 for infants and is progressively greater with older age groups, is above 2.5 for individuals who are 9 years of age till about 50 years of age, and is slightly lower in older adults. Also notice that the sodium-potassium ratio does not vary as much by sex. It's quite similar. This shows the mean 24-hour urinary sodium to potassium excretion. And you'll notice that overall sodium to potassium excretion is 3.17, and it did not vary significantly by sex. This shows the mean estimated sodium to potassium ratio for dietary data to the right of the urine data, and you can see that the sodium-potassium ratio is much lower, significantly lower based on dietary data than it is compared to 24-hour urinary excretion data, both overall and by sex subgroup. This shows the sodium to potassium intake distributions, and you can see they're quite similar for men and women in the United States, and they go from about between 1 to 1.5. It's the molar ratio at the first percentile to about 4 at the 99th percentile. So what are the strengths and limitations of these methods, and how do they affect the estimates? NHANES and the Canadian Community Health Survey primarily depend on dietary recalls, and as shown on the right here and as described by Kay, based on dietary recalls, whether you use a single day or multiple days or usual intake, the mean estimate should be okay for the population. But using a single day of intake is going to affect the variance of the distribution, and you may have inaccurate estimates at lower levels and higher levels. As Kay indicated, there's underreporting of the foods we eat on dietary recalls, maybe except for Oreos. And that this is not eliminated, but it's reduced by the use of this automated multi-pass method, the 5-step method. However, the estimates exclude salt added at the table, and they also exclude salt substitutes, which can be a source of potassium. So it would be a slight underestimate. They also rely on accurate nutrient composition. I'm going to describe the strengths and limitations of those in the next slide. The USDA Food and Nutrient Database for dietary study used with NHANES and the Canadian Nutrient File used with the Canadian Community Health Survey both rely on the USDA National Nutrient Database for Standard Reference, or SR. The data for sodium have been regularly updated since 2010 by USDA with collaboration and funding from CDC and other federal agencies based on both label reviews and on laboratory analysis of selected sentinel foods through USDA's National Food and Nutrient Analysis Program. The databases use standard recipe files, and brand-specific values in the nutrient databases have been enhanced through the use of USDA's branded food product database. As indicated earlier, on the previous label, there were limited label values for potassium, so updates for potassium were not as regular, but we expect that this is going to improve with the new nutrient label. For 24-hour urine collection, potential selection bias and sample size are an issue. And as shown on the right are 24-hour urine completion rates by participant characteristics in 2014. You can see that completion rates were above 70%, all except for non-Hispanic Asians. As Kay indicated, there's random within individual error because 24-hour urine is a short-term indicator of intake, can also be affected by inaccurate timing, but for most of the 24-hour urines collected in NHANES, they were started and stopped in person. The person came to the mobile examination center. Underestimation can also occur with an incomplete collection. We excluded those with incomplete collection based on self-report and urine volume. We also did a separate analysis excluding people with potential incomplete urines based on creatinine criteria and found that the results were similar. As Kay indicated, underestimation can occur because only about 90% of the sodium that we consume is excreted in urine and as low as 50% of potassium. So in conclusion, sodium and potassium intake vary by age and sex. Some of the differences in sex may be related to energy intake, and usual sodium intake varied widely, the long-term average within population subgroups. Dietary and urinary sodium assessment levels were similar, and they tend to both underestimate intake to some degree, and 24-hour urinary potassium excretion was significantly lower than dietary estimates. Commonly consumed foods contribute to sodium and potassium intake, and most of the sodium consumed is not naturally occurring, but is added by food manufacturers and during preparation, not added at the table or by us. I'd really like to thank my colleagues who've been working night and day to prepare draft tables for this committee, as well as colleagues from NIH, USDA, and Health Canada who helped with the data for this presentation, the sponsors, the committee, and collaborators on the studies presented in this report. Any errors are my own and not theirs.